Late at night, a commercial flight lands at Victoria Airport under highly restricted conditions. 4 Canadians step into a strict quarantine protocol. They are met by public health teams operating in strict infection control conditions. Every official managing their arrival is wrapped in head-to-toe protective gear, controlling every movement from the tarmac to a secure lodging facility. But if you observed these 4 passengers, you wouldn't see anything visibly wrong with them. They have no cough, no fever, and no physical signs of illness. They look perfectly healthy. They were pulled into this severe lockdown because of where they had just been, an isolated vessel where a deadly viral outbreak had suddenly taken hold among the passengers and crew. When you are tracking an invisible biological threat, looking healthy does not mean you are clear. It just means the clock has started. The pathogen triggering this extreme response is the Andes strain of hantavirus. It is a rare disease, but it carries an alarmingly high fatality rate for those who contract it. This graphic tracks the biological window, making the virus difficult to manage. From exposure, the Andes strain incubates up to 6 weeks, or 42 days. During this window, a person feels fine, while the virus quietly multiplies in their bloodstream, undetected. That 42-day gap strips public health officials of their usual tools. They cannot treat it early, and they cannot easily identify who has it, forcing them into an agonizing waiting game that dictates every strict protocol they enforce. Most hantavirus cases follow a predictable pattern. A person inhales dust contaminated by rodent droppings, usually while cleaning out a shed or an old cabin, and the chain of infection stops right there with that single individual. This diagram shows what makes the Andes strain the severe exception. While the standard transmission ends at the first human, this mutated version can actually jump directly from person to person. Health authorities traced this specific outbreak back to an environmental exposure before the cruise began, likely deep in a remote mountain valley in South America where this strain naturally occurs. Because of that long incubation phase, the exposed individuals boarded their cruise ship feeling perfectly fine. They integrated entirely into the closed, densely populated environment of the vessel. Once their symptoms finally emerged weeks later, the virus spread quickly to the people providing direct care to them in their cabins. Several of those close contacts fell severely ill, resulting in multiple fatalities. The rare ability of the virus to spread between humans, combined with the isolated ecosystem of a ship, accelerated a localized exposure into an international emergency. When the outbreak was officially recognized, health agencies faced a massive logistical scramble, trying to track down hundreds of passengers who were already dispersing through crowded airports and taking connecting flights around the world. Tracking them down was only half the battle. The primary obstacle facing health officials is their inability to rely on standard laboratory diagnostics to screen asymptomatic carriers. This split screen shows exactly why. On the left, PCR tests look for the genetic material of the virus, but during incubation, the RNA levels are often too low to trigger a positive. On the right, antibody tests look for the body's defense response, but that reaction takes weeks to build up. These diagnostic blind spots mean doctors cannot confidently clear a passenger. The only reliable tool left is a physical barrier. When medical testing fails to provide immediate answers, absolute physical isolation becomes the primary weapon of public health. Hearing about global tracking, secure quarantine facilities, and rising case fatalities inevitably triggers immediate anxiety. It echoes the early, uncertain days of the COVID-19 pandemic. But from an epidemiological standpoint, these pathogens behave very differently. The Andes strain is not a highly transmissible airborne virus. It does not sweep through a ship's ventilation system or spread via a passing cough in a hallway. For the hantavirus to jump between people, the mechanics of transmission require sustained, intense exposure. The infections track closely to individuals who shared prolonged intimate contact or provided direct hands-on care to someone severely ill. That biological hurdle naturally restricts the pathogen. It creates tight, localized clusters among specific groups, rather than expansive global waves. That scientific reality does not lessen the psychological weight for the isolated individuals. They face daily wellness checks and total separation from society for up to 6 weeks, waiting to see if a simple headache turns into something worse. Behind their closed doors is a massive, invisible network. Local public health teams, federal agencies, and global organizations are coordinating daily to enforce these boundaries and share monitoring data. It demands a heavy price. The quarantined individuals endure a grueling disruption to their lives, while healthcare workers manage the constant logistics of safe transport, specialized gear, and daily clinical observation. But this exhaustive 42-day isolation protocol is exactly what protects the broader public. By holding the line through the entire incubation period, they ensure a localized outbreak